From the campus of the University of Kentucky, you're listening to Behind the Blue. I'm Cody Kaiser with UK Strategic Communications.
20% of kids in Kentucky live in poverty. That is at least 6 or 7% above the national average. So when you think about that and you think about the socioeconomics, and most people think it's Appalachia only, it's not Appalachia only. You can look at some of the cities. You can look in the city of Lexington. You know, there are parts of Fayette County that your life expectancy is different based on your zip codes.
And that's always the question, though, for pediatricians in general is how far upstream can we go with prevention? What does it look like to prevent that hospitalization or that bad outcome? What does it look like to prevent the diagnosis or the disease in the first place? What does it look like to promote a healthy childhood? And what does it take? You know, it's often said that prevention is cheaper than treatment, which can be true, but it's not free. So even as we're thinking about those kinds of measures, it's a question of how do we invest actively in those things? How far upstream can we go? And what investments can we put there so that the downstream effects never happen?
That's Dr. Scottie Day, Chair of the Department of Pediatrics and Physician-in-Chief of Kentucky Children's Hospital, and Dr. Bethany Hodge, Vice Chair for Population Health and Strategy in the Department of Pediatrics. When we think about children's health, we often picture checkups, vaccinations, and the day-to-day care families receive from their pediatricians. But in Kentucky, the conversation goes much deeper. From rural access to care, to systemic poverty, to the lingering effects of the opioid epidemic, children across the Commonwealth face challenges that begin long before they step into a doctor's office. At the same time, Kentucky Children's Hospital and the University of Kentucky are stepping up with bold strategies aimed not just at treating illness, but at building healthier communities, starting from the ground up. Through statewide partnerships, data-driven interventions, and a renewed focus on population health, leaders are rethinking what pediatric care can and should be. On this episode of Behind the Blue, Drs. Day and Hodge discuss the evolving needs of Kentucky's youngest patients, the launch of the KCH Affiliate Network, and how a commitment to upstream care and community collaboration is shaping the future of children's health across the state. Dr. Bethany Hodge and Dr. Scottie Day, thank you so much for taking the time to be with us and talk to us. Let's just start by kind of setting the scene, and I'll let either of you go first to talk about this. When you look across the state, what stands out most about the current landscape of children's health here in Kentucky?
Yeah, I mean, I'll offer some of this to Dr. Hodge. I think that in many ways it's come a long way. I think there's been just amazing accomplishments in some of the areas of Kentucky. Despite that, we still have children living in poverty. We still have children living in food insecure homes. And so, and we're fighting in some areas with economic challenges that we don't really see anywhere else. You know, 20% of kids in Kentucky live in poverty. That is at least 6 or 7% above the national average. So when you think about that and you think about the socioeconomics, and most people think it's Appalachia only, it's not Appalachia only. You can look at some of the cities. You can look in the city of Lexington. You know, there are parts of Fayette County that your life expectancy is different based on your zip code. So, you know, a lot of those come through that. And I would say the accomplishments have been quite magnificent of what investments have been made. But it's not a one and done type of thing. It's just like the beauty of a children's hospital and a children's healthcare system is that, yes, we do fix broken bones, and broken bones are so important. Don't get me wrong. They allow you to play. But the other part of it is investing in the moms and investing in the long term, because ultimately, you know, luckily the mortality from childhood illness is fairly low in the big scheme of things. However, we're looking at lifetimes, and that's why we used to say it's not about saving lives, it's about preserving the lifetimes. And so, you know, that's kind of our mission and our vision and kind of the way we look at it from a state.
I would add, too, that while we have rankings and things like that maybe in the lower half of the United States for a lot of the things that we are hoping to improve for children's health, there have been improvements made. And I agree with Dr. Day that a lot of times it has to do with looking at how we are operating within our families and our communities and how those situations are helping or not helping kids to reach their potential. And so the urgent issues are things that all involve how the environment in which they're growing up, as far as the supports and the opportunities that they have, the barriers that their whole family faces, and how they're able to meet those challenges.
That makes me think about, when you talk about it's important to treat these things that are that have an immediacy to them, but also, so you have to have resources and you have to have the skill set and you have to have the capabilities to address all of those things, but also it does put you in a place of kind of, you have to stay on top of other things as best as you can in order to so it while you're treating these more acute things, you have to use the opportunity to also work in education and preventative health measures and those types of things to impress upon families like the importance of X, Y, and Z. So it's kind of like you kind of have to juggle two different jobs at the same time.
Yeah,
almost.
that's absolutely right. And I'm a pediatric hospitalist by training, and Dr. Day is critical care. So a lot of times we're meeting families on the day that they really hoped would never happen, which may be the end of the line of a series of events, some of which we can control and mitigate, some of which we can't. But now they've ended up in the children's hospital with a sick kid. And that's always the question, though, for pediatricians in general, is how far upstream can we go with prevention? What does it look like to prevent that hospitalization or that bad outcome? What does it look like to prevent the diagnosis or the disease in the first place? What does it look like to promote a healthy childhood? And what does it take? I was listening to some things that it's often said that prevention is cheaper than treatment, which can be true, but it's not free. So even as we're thinking about those kinds of measures, it's a question of how do we invest actively in those things? How far upstream can we go? And what investments can we put there so that the downstream effects never happen?
Yeah, talking about us ranking, Kentucky ranking near the top for things like childhood chronic illness and poverty, that's a reality that does show up in day-to-day work with families. There are a lot of ripple effects that end up on the providers on the front lines with that, correct?
Yeah, absolutely. And it's such I think people underestimate the economic impact it has with a sick child or even a child that's undergoing this. I mean, it's, you think about the immediate needs of the parents, right? If they have a kid with a chronic illness, imagine living 3 hours from here, right? Trying to manage a child with complex issues, trying to keep a job, trying to do all those things that are important. But it's also, it's important as well to understand that it's for those communities. A lot of times we don't want every single person to come to Lexington. We don't want them. I mean, we are happy for them all to come to Lexington, but we realize it's a big deal to be, even if you're in a hospital for a couple of weeks, even if it's for a week and you have multiple kids. I mean, we see families struggling in ways that people just don't understand. Mm-hmm. And it's not just the ones living in poverty. I mean, these are all classes of family, right? Struggling for some of this. And we have had very successful partnerships where that we've had, companies that have come and said, hey, we have a strategic plan to be in this city for the next decade, or even some of them even longer, actually. We need to understand what can we do, one, to keep the workforce here, right, so that they're not missing work, but two, how are we going to continue to build the workforce for the future? And I think a lot of that for us has been through partnership, because we are the, I don't want to say it's the glue, but often for children, we may be the ones that at least are at the table, but we don't want to do it all because, I grew up in rural Kentucky myself. Like, we have to partner with those people. It can't be one of those things where we come in, we're happy to come in, we're happy to do things, but really the biggest part of it is figuring out who our partner is in those regions. And we've been very successful with that. I mean, I would call out so many people in different hospital systems, even from different organizations. I'll use the Face It movement and child abuse. CoSAR Charities, I mean, there's been a substantial dent in child abuse in the state of Kentucky. Like, it is very recognizable. The most of it's been in mortality, but at least the awareness. Now, the rate's still high, but it's nowhere what it was before. And a lot of that, I would say, to the work of, CoSAR, which is the organization that's been working on this for a while, the Face It movement. There's so many people that come together to do that. Even on this campus, if you look at, Dr. Howard and her team, Dr. Sprang from different departments, you also have the College of Public Health. Like, there's so many different avenues. So these are the only way we will resolve these problems.
Yeah, that whole thing of access, whether it's, especially for rural families, the barriers of that, whether it's transportation or insurance or specialists or a combination of all the above. Conversations I've had about UK healthcare in general with like Eric Monday about kind of the where the vision is for kind of these partnerships. Yeah, if you've got to come here and you've got something that needs that specific special treatment, you can come here and get that. But we're going to try to get you out the door as quickly as possible, and maybe back to your regional close to home hospital so that you can do your recovery there. I feel like that's such an important part. Like, you can come here for the more specialty oriented things or for the things that you can't get an answer to there, but those partnerships of trying to work out, like, how do we get you back in your home community? Because those are oftentimes the best place for you to recover. I think that's kind of something that I think is probably an important aspect of it. In response to the complexity of all these challenges, how has Kentucky Children's Hospital grown or adapted? Like, what's changed over the years in order to kind of address and meet all of these needs in that sense?
So prior to the pandemic, we had a strategic plan, and part of that plan was to increase access to everything. Because the difference and to echo Dr. Monday's comment, that we do want to be the tertiary quaternary referral center. And that works for almost everything. Pediatrics is not always that easy, right? So, and what I mean by that is there's such a scarcity of pediatric specialists across the country. And that's not getting any better. I mean, the statistics are scary, actually. If you look at the aging population of pediatric specialists and you look at the number going into fellowship, it's frightening, actually, to look. And this is not just Kentucky. This is the entire United States. But I would say that, so a lot of things that you may be able to do in the adult world in local hospitals, a lot of times there's not pediatrics. And then what happened in the pandemic is even those few hospitals that were still doing pediatrics, they had to up their volume for adult, and they couldn't maintain the overall skill set to maintain some of those. The exception of that's NICU. NICU is one of those that we have partners in. So, and every partnership looks different. So we have a partnership with Frankfurt. We have a partnership with Corbin, Pikeville. I mean, you name children's hospitals, we have a partnership. And every single one of them looks different. They look different for many reasons. One time they look different because of the resources available. Sometimes it's different based on, what kind of service needs they need. Sometimes they're our physicians that are employed by us that work in those communities. Sometimes they're partner physicians where we just work to kind of make sure they have the protocols and the kind of the medical direction. So one of the things that we really wanted to undertake is just a massive recruitment initiative. And we've recruited, by this year, probably in 5 years, we recruited about 90 pediatric physicians of some sort.
Wow. You
add another 30 to 40 APPs, you add another research core. And so we've had this massive recruitment efforts. And I think part of that, Dr. Hodge will talk in a minute. When we recruited her, which was an unbelievable recruit, but I think some of the recruitment has been that we are very mission driven. So when I first started, when people would interview, and I'll use, let's say, Boston Children's. I was like, we are not a Boston Children's Hospital, because at the end of the day, we will provide the care at or above what they provide to each and every patient, but we are not going to be necessarily billboards all over the world saying this, because our mission, which aligns with the university's mission, is we are the Children's Hospital for Kentucky. So one of the examples I give is that if you want to come and study zebrafish, you may not do that here, but actually you will, because it's part of oncology research, ironically. But I'm saying is we're going to study the things that affect the state, because at the beginning of the Children's Hospital, even at the beginning of the university, this university was charged with making sure it's educating, research mission and then clinical mission. That's what we're going to do. And it's going to be the absolute best care. And so we've done that over the year. Recruitment's been very successful. Now we have to, there's a lot of components to that. We've expanded, our volumes went up substantially. And the volume actually has went up. It's been a couple of reasons. One is kids can stay in state when they couldn't before. We have specialists that weren't available before. I think some of the work that we've done has been a cross-campus collaboration. We do a collaboration with the College of Education for the ABA therapy. Kentucky Children's Richmond Road, which is one of the most amazing facilities that I think we've ever had, that's dedicated completely to complex and developmental children with complex and developmental needs. That's a partnership with Easter Seals that also works with the College of Education. And so I feel like the reason that we've done so well is because we always go after this with partnerships. If we think about the network that's growing, and we can talk a little bit about it, but the affiliate network, we launched it. It's been a vision for a while. Christina Briggs and the team, which has been working on it. I mean, we already have 4 signed on because in general, people care. And the reason they care is they care for that community, but also when they become a part of our network, we recently signed King's Daughter on. That just says that their hospital cares enough about their employees that they want their employees' children to have the absolute best care. And to me, that's where the success has been in a lot of these. It's the same here. A lot of what we're doing, including our expansion that we're doing, I mean, University of Kentucky is not a small employer. Like, we have to be able to take care of our own people in addition to taking care of the rest of the state.
As an aside, and before we get too far away from it, you were talking about the drop-off in pediatric providers. Is that, just for my own curiosity, is that because the number of medical school students are choosing other areas to go into, or the amount of children who need, like, there's a growing amount of need, or all of the above? Yeah, that's kind of what I was wondering.
Yeah, we're concerned about the pediatric pipeline of the workforce, and there are many. I have done a lot of medical education in my background, and many people who like kids and think that they might want to do pediatrics, and then some of the realities of what the work is like, that you actually are working with parents a lot, and that turns off some people. And then, frankly, that primary care in pediatrics is not as incentivized financially as other things you can be with the same degree. And so when students have debt or are looking to provide for their own families, then it's a hard choice to go and dedicate yourself to a profession where it may be a struggle to pay back your loans or do some other things, or just it's not as enticing. And we also face some, not the highest, but not the lowest rates of burnout too, throughout the pandemic and even before that. Pediatrics can be hard on your soul. And so it's a specialty that great people go into, and it's, I wouldn't want to do anything else different with my specialty, but it can be a hard choice for some people.
Mm-hmm. And I would say the specialists or if you look at all the specialties in pediatrics, general peds, it's hard to get people to do general peds, but even after they do general peds, for the most part, with the exception of maybe 4 specialties, the rest of them, they end up making the same amount or less financially if they do 3 more years of fellowship after doing 3 to 4 years of residency, after doing 4 years of medical school, after doing 4 to 5 years of college. Mm-hmm. And so what's happened, and it's a kind of a complex thing, and I'm on a task force that looks at, is the student loan debts are so large. You come out and you make a pediatrician, it's just not there. Now, what I tell students is, I can ask everybody in this room in medical school, and I guarantee all of you guys will remember who you saw as a kid, but I guarantee none of you will know any idea who you saw last as a physician, and they do. They always remember their pediatrician. So it is an impact, but it is burnout and other things. And I think it's not gotten any better. To do a pediatric, I always use pediatric oncologist or hematologist oncologist who, they're absolutely amazing, right? They probably financially are about half of what an adult provider. And that's not because that's just the way the country is set up currently. Mm-hmm. And I'm not saying one's any better than the other, but that's the realities when you're coming out with an average of $300,000 or more student debt. It's just a lot, to be able to make that choice. So, we have pipelines to try and incentivize those, but you can only do so much. And And I think some of the population around developmental, some of the populations have increased beyond what we've seen before.
The better we are at our jobs to make those tiny baby NICU kids survive, and for people to be able to thrive despite a genetic diagnosis or some other sort of early childhood disease, the better we are at our jobs, the more tricky it can be as well.
Yeah. When I was training, we would have cystic fibrosis is one of the greatest examples. I mean, you would have wards full of kids and teens with cystic fibrosis, and you would anticipate the life expectancy for them would not be, more. Sometimes it was 20 plus years. I mean, cystic fibrosis is up to 60 years, 50 to 60 years old.
Wow.
Now, I mean, that has leaps and bounds above what in the past. So medicine has come so far, even from a neonatologist, Nikki, to her point, 350 grams, that's the size of a Coke can, will survive and go home. And some will have needs. Most of all of them will have some needs, but some can function very well. I mean, the push in medical expertise is unbelievable. Trisomy 18, we have a very popular patient she's surviving, she's doing well, she's 5 years. So there's so many ways that it's advanced, and they're living meaningful lives. And so that has changed the dynamics of what we're seeing in the hospital, what we're seeing in the clinics. But it's a good thing. It's not a bad thing. It's a good thing. We just have to figure out how to manage it.
Well, looking at that kind of adaptation and addressing needs, meeting the needs, Dr. Hodge, your title says a lot, Vice Chair of Population Health and Strategy. And
yes, it's very impressive, isn't it?
Right. And we had the discussion before we started recording about the wording of that and what that entails. But it is a big picture role in a space that's often been focused on the bedside. Why do you think now, maybe personally for you, and then also kind of for KCH, like why was now the right time for this kind of position?
There's a lot to unpack there, I think. So, as I said, I'm a hospitalist, and if I am your child's doctor and we're in the room together, that's my whole world for the moment, right? That's my puzzle to solve. That's our problems to work through, and that's a good thing to have a physician, hopefully, that can have that perspective. I also have a background in public health and global health, and so I think I'm just built a little bit differently too, that once I see the same problem 3 times, I'm going, what is going on here? And once I start connecting it to these kids are the same, they're from the same neighborhood, or they have these same things about them that are features of their family or their upbringing or the situation or the community resources available to them, I start thinking about the larger context of the children. And then it becomes that challenge of, okay, is there someplace upstream where we could be intervening or a resource to build in that we could really change the dynamics of a situation for a whole group of kids? And whether or not that means that they do or do not end up in the hospital room, that could be part of it. But it's a bigger picture, taking into account a lot of things having to do with culture and access to resources, barriers to care, and trying to put it together. That's where the strategy part comes in. Okay, now that we can recognize things, what are we going to do about them? And what are solutions that are going to hopefully float all boats and really affect things in a positive way?
It's interesting, public health, the concept of public health. For people who may listen to Behind the Blue over the last several months, there have been some things that have kind of threaded through there with public health. I've talked to some recent graduates from the College of Public Health. There's been, and even away from my producing of this podcast, there's just been some conversations I've had with people about how much more in the forefront. It's just been really like much more kind of the moment, like the focus on public health. And for people who may not know, like when we say population health in a pediatric setting, like what are we really talking about, and kind of what sets that apart from traditional care models?
Great question. I think that's one of those that you ask 5 people, you might get 5 different answers on what population health is and how it's different than public health and things like that. It is very outcomes forward. So thinking about the things that you're noticing that we want to change, and then trying to work backwards from that to figure out who's affected, what may be going on there, what are potential interventions, things like that. So I also work for the Kentucky Department for Public Health as part of my previous job and as part of this job. They are very great at the technical work of surveillance and knowing what is going on. And what I'm hoping with this position and with the backing of UK and the UK healthcare system is to be able to be active with that information and the information that we gather as our own system, to really put legs underneath it and see where we can go. So not just observing or counting, fulfilling regulations and things like that we have to do at KDPH, but focusing on pediatrics, which sometimes doesn't get as much attention since they're not as much of the population and they don't vote and they don't own businesses. What does it look like to really focus on the public health data parts of pediatrics and then the population health action parts of pediatrics?
So this is in a lot of ways connecting the dots, not just between clinical departments, but state partners, public health agencies, hospitals, and a lot of other aspects across Kentucky.
Absolutely.
Yeah. And I would call out too that specifically, the creation of this position and the fact that we were able to find and recruit Dr. Hodge, we sold her, the horse farm in Lexington. I'm joking. But part of this was through a partnership too. So this was through a Coaches for the Kids Foundation, which is a foundation that supports the Children's Hospital. And we approached them about many, many issues affecting children. And instead of, I think the beauty of it, instead of just looking at, John here in, I don't know, Somerset, Kentucky, and Rob over here in Pikeville, and Mary in Bowling Green, like when these come in, we need someone to say, okay, how are we gonna approach this so we've seen a trend, to her point? Or even within the city of Lexington, right? We have some great organizations through the Mount Foundation, et cetera. How can we somehow provide this kind of information to help at least recognize things? And we could go into so many, a lot of times people think public health is just about the measles, right? Mm-hmm. But it's way more than that. It's way deeper. It's just when they get most of the news, right? It's when there's a massive pandemic or if there's a measles outbreak. But population health is so much more than that, right? And I think to her point, it's about the quality outcomes. I mean, you mentioned talking with Mr. Birdwhistle around some of the Medicaid stuff. And some of that in the last years is really geared towards looking specifically at outcomes in these populations. And actually, the program currently has been extremely successful in increasing well child checks, increasing screening things, increasing prevention things. And what's happened is that we've went from a system who basically, responded to when something happens to say, okay, how much of this population of Medicaid are getting their well child checks, and are those happening? And that has been, and I call out Mr. Birdwhistle, he's a big component of creating that. That's been a huge success to the program in Kentucky, because if you look at the statistics, it's actually quite impressive what we've done in that population. Doesn't mean we're done, but it's just switching that mindset a little bit. And I would say it even involves the moms. Like we're talking so much about the children's. Maternal health is so important. And I know Dr. DeFranco, who's our chair of OBGYN, has been heavily involved in it, but maternal health is so important in those children, right? And we talk about upstream. If you look at what affects the ocean, you got to go all the way up the Mississippi, up the Ohio, and even farther up. And so that's the part that we have to look at as well as maternal health.
Is some of this, I kind of want to transition to talking about this. Is this, maybe we've touched on it and I've just blanked on it. One of the developments that we've seen recently is the launch of the Kentucky Children's Hospital affiliate network. And is that tying into that in some way, or is that like...
It is. It's part of it. So it doesn't tie directly in. Some of it could tie into those metrics that we talk about for some preventive metrics, but that network, which is one of its first of its kind, was actually something that we kind of talked about a couple of years ago, is how do we partner to make sure that if a child ends up in whatever ER, that they at least have what's needed, right? And some of that was born out of the Peds Readiness Program, which is a program that sits with EMSC, which is a children's. And I was involved in that years ago. But and a lot of it has nothing to do with equipment. I think that's often where people, when some of this comes in with ERs, it's really not about the equipment. It's just the comfort of seeing a child when you only see a handful of children, right? We already talked about how there's a lot more adults than there are children, is how do we make sure they're prepared? And it looks different at every place. So if they're part of the network, then we help with medical direction, we help with training and education, we help with all those different things. And there's different tiers to that. And that's, we've had the first one that signed on was Georgetown, Somerset signed on. Ironically, the day we did the ribbon cutting at Somerset was the day of the tornado. I was there that morning, and that evening after we cut the ribbon, they had a massive event, right? And it was just, how do they get prepared? Subsequently, King's Daughter, and now we have Manchester, and there's more coming on. Line, but part of that is they're saying, hey, we're committed to this. And that a lot of that's around education and training. A lot of it's around making sure the quality is the same. A lot of those hospitals do not admit children. Some do, some don't. Some have NICUs, some don't. And NICUs, there's different levels of it. It just depends on the institution. And we tailor it to it. For example, there's some that have just a great deal of experience and they're part of the network. And we say, this is, these are some of the protocols so that if a child's in wherever that may be and they're part of the network, then that, hey, there's a constant communication and it's part of it. It's evolving. So we really just started in the last couple of months. And then there's the bigger Advancing Kentucky Together network, which is a larger kind of network that encompasses more than just children's. I mean, we're a part of that, but that is a huge commitment as well beyond just Children's Hospital. And I think a lot of those are coming up. And a lot of that really builds upon what you talked about, that Dr. Monday talked about, is how do we partner? We don't want every single patient in Lexington, adult or children. We want them to stay in the community because that's what makes Kentucky a healthier place.
I think what I like about the affiliate network framework as well is that it allows facilities to exist on the spectrum where they choose to be, but encourages them and empowers them and gives them skills, information, capabilities so that they can move along in their children's care areas if they choose to, right? We're not expecting them to be little mini children's hospitals.
Right.
We're hoping that they can take care of a few more kids or a few more adolescents or be more comfortable with their stabilizations before they are sending them to us and things like that. But it lets them be where they are and what's the right thing for their community, but gives them access to ways to think bigger.
It at least sets a baseline so that no matter if you're in Pikeville or Paducah or anywhere in between, you can expect the same level of expertise and support as you would if you were here in Lexington.
Absolutely.
Yeah.
And I would say different places have different needs. They have different populations, right? So you can imagine being in one part of Kentucky, like Georgetown. It's got one of the highest birth rates in the state of Kentucky. So they are going to, by nature, although they're close to Lexington, they're still going to have a different look than a different part of the state where the birth rate's either flat or lower. Once again, though, maybe there's certain factors of illnesses that affect that geography that don't affect those. And so there are tailored to that. I'll say the other part that I really want to advance with the network, and this is not just the Children's Network, this is Advancing Kentucky Together Network, is how do we evolve technology to work? And I'm not talking about just telemedicine. I mean, this institution's been doing telemedicine since Dr. Noonan was still here and they were doing telemedicine. I'm talking about really advanced type of networking. So, for example, we have what's called the LOCUS program. And you don't have to be a part of the network for that, but this is a program where that we can discharge babies. We've had some complex patients with congenital heart disease. We've done this, and the parents have a monitoring system that are at home. So they actually, and it uses a device to do it. So instead of them necessarily going to the local ER, they just pick up the phone, they get a hold of the provider can look at the data on that baby and say, okay, maybe everything looks okay. Or maybe, hey, you know what, you need to go to the local ER. Or two, maybe you just need to come to the clinic tomorrow. This technology is evolving faster than we can keep up in many ways. But if I feel like that we have the opportunity to figure it out in a population that could have great benefit, whether from geography to socioeconomics. So we want to be able to leverage some of the network to be able to do some of that. And I'm not talking about just research. I mean, we will do the quality work, and then we'll figure out what works. And a lot of that can be translated because we're not alone. I mean, yes, if you've seen one children's hospital, you've seen one children's hospital.
Right.
But Mississippi, they face some of the same struggles. Alabama, Georgia, like there's a lot of places, South Carolina, that face some of the same challenges. And I feel like that we have an opportunity in leveraging a network to be able to figure out how can we best solve those. Knowing not all of them are going to work, but there's a lot of synergy there. Plus, it's a great place to look for the workforce. How can we help those hospitals to train the workforce they need to stay in that community, right? To stay in Eastern Kentucky or to stay in Southern Kentucky or wherever it may be. Like, how do we bring our partnership together to say, you know what, when you're in middle school, do you know how many things you can do in healthcare that isn't a doctor or a nurse? Unbelievable. Sonographer, which is the people who do the ultrasounds of the baby, they're hard to find across the country. And I think most people don't realize that's a good job. Doesn't require a ton of education post-high school, and it's a good life. And I think we want to be able to do that. And a lot of that's happening, I think, through some of the workforce initiatives, through Dr. DePaula and Dr. Monday and some of the things that are going on with the university. But how do we do that from children? Like, you could basically have a job tomorrow if you want to go and just ultrasound moms and that have babies that may have congenital problems. I mean, these are like real things. So how do we use our network to tell middle schoolers, you know what, you can do something in healthcare that isn't a doctor or nurse. Now, we want pediatric doctors, right? We want them to, we still want them.
Sure.
But there's so many other things, because sometimes you look and you're like 4 years of college, 4 years of med school, 3 years or more of residency. That's a long time. And some will say, I don't want to do that. And I don't want, that much debt. Well, there's so many other things you can do and have a really good life and make a significant contribution to society.
I think it does contribute to that. Like, in talking about that, I think about, we have so many students who come here who, we talk a lot about students who come from rural areas in Eastern Kentucky or Southern Kentucky, wherever, who come here and they just stay here. They stay in Lexington or they go into someplace bigger or whatever. But we have so many stories of those students who come from a small town, they come to UK, and all they really want to do is get their education and go back to their home community and apply what they've learned and do what they do in those home communities. And so, like, that idea of being able to come here and really kind of see all of the potential and the expertise and the things that go on here, and to be able to go back to their home community and apply their knowledge and their skills of that to help develop that and lift that area up, I think is that just ties in so well with some of this stuff.
Yeah, and I would say, I'm advisor for a group called Appalachian Health Initiative, and it's a great student group. And part of that, a lot of those are individuals that are from that area. And sometimes, I grew up in Eastern Kentucky and went away, and I've been back. I came back. But the beauty of being back has been being able to take care of people. My specialty wouldn't allow me necessarily to be anywhere but in a city as a pediatric ICU doc, but I take care of so many patients from throughout those areas, which is very, very rewarding. And you know what was always shocking to me is even today, if you go to a graduation, it's amazing how many first-generation graduates there still are at the University of Kentucky. It is. I
had that very thought at this past this spring commencement, that how many students stood up that were first generation. Yeah.
The other thing I want to mention, I'll have Dr. Hodge comment. The other thing we have to figure out in Kentucky, the biggest challenge, we have to figure out what to do with the foster care crisis and what to do with foster children. There's statistics tied to that population around graduating high school and other things that are just depressing. And we're working on that with Dr. Howard. He leads our child abuse team and Kentucky Youth Advocates. But that's, when we talk about population health, that's a population of kids we have to figure out what to do.
I totally agree. But it is one of those things that, we start looking upstream. Why are those kids entering into foster care? Well, we're one of the states with the highest incarcerated rates of adults in the United States. Why are those individuals incarcerated. Why is that their life and affecting how they're able to be home to manage their kids or anything like that? And we get back to the opioid crisis. Again, you kind of start looking for those upstream things. And then it can feel like it's beyond the capacity of a pediatrician to really do anything about that. And that's why we have to keep partnering with, the people who see adults and the people who are in the justice system and the people that are across all these areas, because at the end of the day, the place where it all triangulates and affects is that child who is no longer in their home and the lifelong effects of that for them. So it's it's a task where you can't just do it from one place. You can't do it from your own specialty as a pediatrician or from one city and expect to really affect the things that you need to affect. It gets very big very quickly, which can be intimidating. But that's, I think, going to be part of the interesting part of this role.
Yep. And the fact that we are, the advantages of being in a health system that has the ability to influence and have the ripple effects throughout generations, which is really what I think somewhat sets us apart, in that we are all one campus and we are all aligned as one university. So it's not this hospital down here, this college here, and this university here. It is all one university, which has really evolved over time. I think it's become clear in the last probably 6 months to a year or longer how clear it is how aligned healthcare is with the university. And I think that gives some advantages that people probably don't always appreciate. But having that kind of alignment is very advantageous for us.
Well, yeah, I mean, just the idea of, 10 years ago, or maybe even more recently, most people would assume that when people think about the University of Kentucky, the first thing that they think about is athletics. They think about basketball. That's the tie-in. But yeah, more and more UK healthcare, the treatment that people receive, the quality of care that people receive has really started to kind of show that is also, something that's on the forefront of people's minds, that they recognize UK because they see it in their own communities. They see UK as being a partner with so many things.
Yeah, and I would say that the community, athletics, and I'll just call it, like, they have been extremely strong partners for us. And I have been completely, from Coach Stoops, from Coach Pope now, from Coach Skinner. I can name, I'm probably going to forget coaches. I apologize. But their involvement and really Coach Mitch Barnhart, not Coach, athletic director, their installation in their ideas of when these kids come that they need to get back to the community, we have greatly benefited. And I'm not talking about financially necessarily. I'm talking about the fact that those players come into the hospital and hang out with kids that are going through their worst nightmares, right? Or their parents are. And I cannot say enough of how grateful we are that, one, they're allowed to do that, but two, it helps build them as individuals. And so we're very grateful for all the teams, women's teams, men's teams. Pretty much everybody has been involved. Even the soccer club in town, LSC, has also had their professional athletes come, and they host events. Like, for a lot of these kids, like, it is unbelievable, because you can imagine, a kid who's in the hospital every single week, whether it be from whatever diagnosis it could be, and even from the parents, it has such a big impact on those kids. So, we are very grateful to have the university, because, as you know, sports is a big thing. Right?
Well, and even students who are not tied with athletics,
absolutely.
Students who are not tied with going into a healthcare field or a degree in that area, just through, for example, their association with, like, Dance Blue.
Yeah.
And the work that they've done with the oncology clinic, and the students who show up weekly, day in, day out, to be with those kids, be with those families, and give their time to be a part of something when they may not even be going on to work in a healthcare field. They may be going on to do something different, but their experience with Dance Blue, like that student awareness, it permeates in a lot of different areas across campus. Just kind of wrapping up kind of what we're talking about the affiliate network, and looking at all these partnerships. And anytime you're working to improve systems or innovate, there comes that risk of disrupting what's already working. So how do you approach that balance between change and continuity of what is already kind of working there in those places?
So I'd say that I have some experience in that area from global health, where it can be very tempting to kind of drop in with your team of physicians and nurses and things like that, and do clinical work or other sorts of things that is appreciated, and people like it that you're there and you're providing a service, but it is disruptive in a way that it sets up something that might be parallel to what they already have in country, or seen as a replacement or a slightly more exciting replacement for what they might be able to usually get there. And that can be a negative kind of disruption. By each individual patient, they may appreciate it, but for the system itself, it's not building capacity. It is focused on other things. So I think what Dr. Day is saying is that everything is done in partnership. It's by listening and saying, what do you, community, want to see in your community? What do you think your problems are? What are the resources that you do have? And how do we build on those things? And how do we increase capacity where you want to increase capacity, not to come in and replace or build something parallel alongside of it that could be distracting. And so it has to be connected. It has to be thoughtful. It has to be strategic and in partnership.
Yeah, no, I agree. I mean, it's about making sure, and to her point, I think global health has been probably the greatest place where we learn. And it's not that we're going into third world countries. That's not what either one of us mean by that. I just mean we don't want to disrupt something that's already there, unless it's, there's appetite to have change. If there's not appetite to change, then it may not work out. I mean, we've had, not with the affiliate network, but we've had partnerships across the state where they're doing a great job. They don't really need us, right? I mean, they think they need us, but they don't. Or it may be that they need things that we just aren't equipped to provide. For example, every single hospital and every single clinic would ask for a developmental pediatrician right now. I mean, there's that many kids that need that need. We just don't have it. I mean, the state of Kentucky has very few. I mean, we're fortunate to have a couple here, but that just doesn't work. And so in some of those areas, we just aren't able to meet those needs. And honestly, for that one, nobody in the country can meet those needs right now.
I think it just goes back to that idea of, as a university, looking out across the Commonwealth and saying, going to communities and saying, look, we are not going to come in here and tell you how to do things. You know your community best. You tell us what resources that we could provide. What do you need from us in order to help kind of supplement what you already have going on?
And I think you can also approach it from the perspective, there's something called reverse innovations, where you figure out this community is doing something awesome. And how are they doing it? And how are they getting these great outcomes? How is this small school having such high reading rates? How is this small local health department connecting people to vaccines in a way that we've not been successful in other parts of the state? And going to them and saying, teach me your ways. Mm-hmm. And then how can we apply that to our bigger system here? A lot of times it's cheaper. A lot of times it's innovative. A lot of times it's community focused in a way that gets lost in big systems. And so it's a great place to learn.
I want to wrap up by kind of talking about, UK having a mission to serve all of Kentucky, not just Lexington. That land grant commitment that the university's always had. How do you feel like the work at Kentucky Children's Hospital is kind of, if you had to summarize that in a kind of a 30-second from ground floor to top floor elevator speech to somebody, like, how does KCH really reflect that land grant commitment?
So I think that commitment obviously started way before the Children's Hospital started. We have a council of people who actually, some of which were on the original creators of the Children's Hospital. And I often talk about that we have a chance to stand on the shoulders of giants, right? One of the most well-known pediatricians in the world is Jackie Noonan, who was here for many years. I knew her personally. Her contribution is unbelievable. And I could name so many others that we've done that. And what was interesting is a lot of their mission, was to, and if you even look at the history of Chandler Medical Center, a lot of it was to serve a population of people that were in need, right? And so, and that goes beyond just serving from a healthcare standpoint, but even the university is how do you educate? I think as we've evolved as a children's hospital, we have had the opportunity for many reasons to be able to be I don't want to say maybe a source of expertise, probably isn't the right word, but at least I don't know if it's a Switzerland, right? Like we're the I always say it's a very friendly environment to help guide the rest of the state on what we feel like is the right initiatives. And those change over time. And I'll give you a great example. So when I started this job as a permanent lead of the Children's Hospital was in 2019, actually. I'd done it a little bit for acting. And one of the things that we knew was coming was the mental health issues, right? We knew that this was coming. What we couldn't predict is that we would have a pandemic in 2020 and suddenly everything changed, right? Suddenly schools changed. Suddenly the mental health crisis got much worse than it's ever been. And so often as an institution, we evolve to be able to respond to the needs of the children and families in the state. We were already on that route of needing more, but that accelerated it. And so we kind of had to both maybe redo part of our strategy, but one of the things that we noticed is that we often guided what the rest of the state would do. And I think that's a responsibility that this place has that doesn't exist everywhere, because there is the Children's Hospital in Louisville, which we do some things with, but in reality, we have a larger geographic region. And what we learned through a lot of the mental health work is when we came in and had consultants and we were looking, okay, how are we going to address this, right? This was post-2020. And what they learned, there was like, well, who's in competition? And we're like, there is no competition. And actually, as they interviewed stakeholders, they're like, we're going to do what the University of Kentucky and the Kentucky Children's Hospital feel like is the right thing to do. And in many ways, there's nothing more humbling, but there's also nothing more overwhelming, right? And we partner with parts of the state. And so in many ways, our mission will sometimes evolve in specific areas. Mental health, we have a division of psychology with Dr. Marsack. We have psychiatry with Meadows. We have a whole massive mental health team, and that's all they do. So that every patient, our goal is every patient that comes into our facility has the ability to be able to see and be able to get mental health counseling, right? And sometimes we partner with other outside areas so that they can do that. We're not going to do that necessarily. Every kid's not going to come here, but at least providing some guidelines for that. So we did somewhat shift the mission to doing that. But the mission goes beyond just seeing those kids for counseling. The mission goes to how do we train more people to see them? How do we partner? How do we partner with the College of Social Work, the College of Education, or whatever that may be, to understand what those are? And so the day-to-day, what gets most of the attention at the Children's Hospital is the kids that come in with the acute illnesses, that have the traumatic event that recovers, the NICU baby, all that, right? That is what most people associate with the Children's Hospital, or a child with a cancer diagnosis. And those are so important. But I will tell you, a huge part of what we do never comes into the Children's Hospital. And that it really resonates with the university. A majority of our mission, the Children's Hospital, if that's all we did was what was in those walls of that Children's Hospital, we would still be doing a great job. But our work's so much beyond that. And the creation of Dr. Hodge, the position she sits in, is about that, right? It's about that larger scope kind of thing. How do we improve mental health? How do we go upstream? Like, why is it that all these kids are either in the foster system, or why is it that we're dealing with kids in even late elementary school? Why would a sixth grader choose to take their life? Like, what is going on? Like, why is that even an option? And we won't get into all those details, but that is the responsibility that we feel. And I also think, for all of us, one of the things is, not to sound it, but we're just a generation away from being forgotten. And what I mean by that is, as people who have the ability to work in a children's hospital, people may not remember Dr. Hodge a generation from now, or Dr. Day a generation from now. That's why we have to make the most impact we do. And it's not about we want to be remembered or being on some wall or having our picture up somewhere. It's about how can you make the biggest impact. In a book I read one time, it says, I simply don't want to just have visited the world, right? You want to be able to be an impact. And I'll tell you, there's nothing that gives you that ability more than being in pediatrics. And it is a little bit of a sales pitch, but I can tell you there's nothing more rewarding than to have a patient that you've taken care of 20, and you won't even remember them, right? One of them I don't even remember, but them coming up and saying, hey, and not that don't mean that, but we see so many kids, they'll come up and give you a hug.
And they grow and they don't look the same anymore.
They look different than they're a baby. But they have a job, right? We have a neonatologist, Dr. Sloan, who in middle school created something for McKenna David Wall. She is now a neonatologist, right? I mean, we have so many of those stories, and those are good stories because then the legacy, it's not the legacy of being remembered as an individual, but at least the impact you have on the world.
It does seem, as we kind of close out, the big takeaway that I'm kind of pulling from this, and correct me if I'm wrong, but when we look at health initiatives and kind of the pipeline programs and things like that, that really the pediatric population and what Kentucky Children's Hospital, kind of the area that it moves into, it really seems like that pediatric population and what we do with that, when you fit it into the larger role or the larger place of healthcare in the state, it really is, not to take away the limelight or crowd anybody off the stage, but in some ways, where pediatric population health goes, so goes the entire state of Kentucky.
It does.
Well, and I would add too that in pediatrics, what we're finding out more and more too is that sometimes the problems are in the community, but the answer is also in the community. Mm-hmm. And so how do we partner as healthcare people? How do we be in the way of the information? How do we make sure that children's interests are being spoken about at every table? And then how do we make those connections to strengthen the community? Because that's what's going to improve children's health.
And a lot of what we're doing, our mission is state-based. It always has been what's going to affect Kentucky. But it has really guided a lot of things nationally. I mean, some of our work in our quality shop with Dr. Chaudhry, some of the work we've done on the state level approaching these are model programs that other states have adapted. And we're a part of those networks before. Our congenital heart program, it's nationally ranked with our partnership with Cincinnati Children's. That is a model program for the future of congenital heart care. Shriners Hospital with our orthopedic care. And so there's a lot of those examples that we have done to address the needs of the population of our state, but they're often quoted as being models of care for the nation.
My last question as we close out is for Dr. Hodge. As you look ahead to this vice chair role, whatever the title you morph that into, whatever you want it to be, or whatever the guidelines are for you got to stay with it. Your email signature has to stay this. As you look at this vice chair role, what does success look like to you for the hospital and most importantly for the children and the families that you serve?
I think that's a great question. I wish I knew the answer. I keep asking for the thing I can bring to Dr. Day and show him, I did the thing. Aren't you proud of me? But I think it's going to be a little bit more complicated than that. As I've been meeting with lots and lots and lots of people and getting to know the systems and the players here, I've been asking them, what do you think a vice chair of population health can do for you? And I think most of the time when they're meeting with someone with, these titles or things like that, they're waiting to be told what they need to do. Mm-hmm. And I don't know the answer. And so I'm asking a lot of people, what do you think that this role can do for you? What are you wanting more of? What are you wanting less of in your practice and in your community? And so I think it's having that conversation over and over again. And then when I'm hearing this person has this need, this person has this capability, these people are having the same conversation, but they don't know each other. It's going to be bringing them together and trying to make the most of all of the resources we have in Kentucky so that we can build the things that we want to build.
What she said. I mean, I think that's true of a lot of, it's a servant leadership mindset. And also the other component that I meant to mention too is how do we take care of the providers that we have? And so we talk a lot about the children and all the children throughout the state. The other part of the population is the population of people that we work with each and every day. The population of, we talk about the workforce. Well, we have to take care of the workforce. And, the cliche is they always tell you put your oxygen mask on first before the other. And there's truth to that. But I also think that's a huge part of understanding, if a physician, nurse, respirator, whoever, their kid's sick and they're out of, then the work, like there's this ripple effect that people feel. So a lot of it's also, how do we take care of our own people?
Dr. Bethany Hodge, Dr. Scottie Day, thank you so much for taking the time to talk with us about this. And it's such an important job and role that both of you play, and all of the team, staff, doctors, nurses, and other staff. As you were saying, there's so many jobs, so many things for people to do at Kentucky Children's Hospital. It's so important to all the communities around the state. Thank you so much for the work and thank you to your team for all the work that they put in. And we look forward to seeing where our children's population health and adult population health goes in the future.
Thank you.
Thanks for listening to Behind the Blue. Behind the Blue is a joint production of the University of Kentucky and UK Healthcare. For more stories about UK and UK Healthcare, visit uknow.uky.edu.